I do my clinical practice in the East End of London, serving what the statistics tell us are one of the most socially deprived and one of the most ethnically diverse communities in Europe. And in that practice, for the last 3 years, I've been looking after a gentleman who I'm going to call Mohammed Madini. Mohammed is 35 years old. He's married with 2 children. He was from Iran originally, but he's been in the UK for about 12 years. He's obese with a body mass index of 35, and he's got type 2 diabetes. The problem is that his diabetes is proving almost impossible to control, a major, major challenge to us. So shortly after I started looking after him, 3 years ago, as I say, I invited him to have a conversation, and I thought I'd start from scratch. So I said to him, Mohammed, tell me about your food. What do you eat? And he said, Dr. Marshall, I eat very good food, very good food. So I said, well, give me a little bit more detail. And it turns out that Mohammed eats 2 meals a day at this fried chicken shop close to where he lives. So 2 meals of fried chicken and chips every day, 7 days a week. That's his diet. I said to him, do you eat any vegetables? There's a beautiful vegetable market close by to where he lives, and he explained that he didn't, and he told me why. Mohammed lives in a 2-bedroom apartment with 17 other people, mostly family and friends. He doesn't have a kitchen at all, and he has what he called a hotbed rota. So he has 4 hours to sleep in. They've only got 4 beds for 17 people, 4 hours to sleep in bed, 8 hours off. And when he's not sleeping, he likes to go down to the fried chicken shop because that's where he gets nice food, he says. It's where he gets peace and quiet. And it's where he can meet his friends and socialize with his friends. Mohammed is a very happy, contented man in almost every way. But actually, he presents a major challenge to me as a GP. I know that the conventional care that we're providing for him, the managing his blood glucose, his glycated hemoglobin, giving him medication, is not really working. I know that most of his needs are social rather than medical in origin. But I'm unsure whether my job is just to deal with the consequences of the inadequate environment that Mohammed lives in, or whether I should be doing something about that environment, whether I should be helping Mohammed to find a job, whether I should be working with our local council to shut these fried chicken shops. Incidentally, there's 45 fried chicken shops per secondary school in our part of London. How's that for a statistic? There are times, I have to say, when it feels like my job is just to fish out the bodies downstream rather than preventing them falling into the river upstream. And that can be a major challenge. Having said that, in the 3 years that I've known Mohammed, I think I'm starting to have just a little bit of impact, maybe at the margins. I'm getting to know Mohammed. He's getting to trust me, I hope. We're having some interesting conversations. We're building a shared understanding of what's important. It's a difficult, it's a slow, it's a frustrating process, but progress is being made. So when I last saw Mohammed about 6 weeks ago, he'd found a part-time job. He was doing just a little bit more exercise. His blood glucose was just a little bit better controlled, and he was still eating fried chicken. This is what we do as GPs. It's why our job is so interesting. It's why it's such a privileged job, but it's also why it's such a challenging job to be a GP. There are many remarkable things about Mohammed's story, but one of the most remarkable, and what I want to focus on in this presentation, is just how little his care costs in general practice for the British taxpayer. The taxpayer pays for the National Health Service in the UK. So the cost of my team's care for Mohammed for a year is a little under 200 euros. If Mohammed was going to our local casualty department in the hospital the same number of times as he sees me, the cost would be about 1,000 euros a year. And if Mohammed went into hospital just for one 5-day stay, the cost would be about 3,000 euros a year. So for 200 euros, Mohammed sees our practice nurse twice. He sees me 5 times. He has 2 visits to our healthcare assistant, 6 visits to a pharmacist, 4 visits to a legal advisor that we have in our health centre to talk about debt. And he has a very comfortable place to sit, to talk to our receptionist, to make friends with our cleaners and with fellow patients, and to use our free Wi-Fi. So Mohammed's care represents truly remarkable value for the British taxpayer. And that's what I'm going to talk about. I was asked to talk about making healthcare more affordable. And my first response was, why me? And my second response was, why don't you ask an economist to do this? Because I'm not an economist. We have a saying in the UK that economists are people who see things happening in practice and argue that they couldn't possibly happen in theory. Well, unlike that, I'm not into theory, I'm into practice. Like all GPs, I'm very pragmatic. And also like all GPs, I love playing with new ideas. And that's why Robert Arp's book, 1,001 Ideas That Change the Way We Think, has really appealed to me. I don't know if any of you have read this book, but it's a remarkable book that draws on politics, on cosmology, on science, on religion, and traces the exponential growth of human knowledge through the ages. It explores ideas as diverse as Mahatma Gandhi's theory of civil disobedience on one side, through to the question of the paradox of time travel. So let me ask you a question. What would happen if you traveled back in time and accidentally killed your grandfather? I don't really want an answer to that question, but that's the kind of question that this book addresses. One of the many plans that I've got for the next phase of my life, this is the phase that we used to call retirement, but we're not allowed to call that anymore. One of my many plans is to write a similar book to this called 1,001 Ideas That Changed General Practice. And I've already got the top one. The top thing that I think changed general practice is Barbara Starfield's work on making a case for primary care. Phenomenally influential work in many ways. It's surprisingly radical. It changed the way that we think about general practice and about our health systems. It changed general practice from something that felt perhaps threatened to something that was an essential part of a modern healthcare system. So it explained to us the importance of what we do. Starfield provided an incredibly compelling case for the importance of general practice and the value that we as GPs bring to our healthcare systems. And value is the dominant narrative in our healthcare systems if you're a policymaker now. And that's because of the global financial crisis. We're seeing what people call a triple whammy. We're seeing slower growth or cuts in healthcare spend in many of our countries. We're seeing cuts in social care spending, and that's putting pressure on our health systems. And we're seeing greater poverty-induced morbidity of the sort that I described for Mohammed. We know that spending on healthcare can be an investment for a country, but it can also be a real problem. It can also destroy health economies. So if, as this graph suggests, in Spain, by 2040, they're spending 21% of their GDP on health, or if in the United States they're spending 27% of their GDP on health, then the consequences for their economies are going to be dire. So we need to spend money wisely, and Starfield showed us how to do that. That means investing in general practice. Her work has had a massive impact on us, on how we think about our role as GPs. It's bolstered our self-confidence. It's been central to our thinking. If you look on the Wonka website, you'll see a whole library paying homage to the Starfield work. So it's had a major impact for us. But if we're honest with ourselves, and I think this is a good time to be honest with ourselves, it hasn't had as big an impact outside our specialty. Despite decades of describing and refining the purpose of primary care, general practice is still struggling to make its case. Policymakers are still preoccupied with hospitals, and hospitals are still preoccupied with themselves. And that, I think, is a major challenge for us. So in this presentation, I'm going to do 3 things. I'm going to, first of all, review the Starfield case, remind those of you who know about it, or tell those of you who don't. So very briefly describe what Starfield said about primary care. I'm then going to explore why the case for general practice is proving so difficult to make. And then thirdly, I'm going to suggest some ways in which general practice might need to change in order to maintain its centrality to our healthcare systems. And my take-home message for those of you who like take-home messages at the beginning of a presentation, but please don't go out and get a coffee if you do hear it, my take-home message is this. In order for general practice to thrive in the future, we're going to have to focus our attention as much on the value that we bring to our health systems and to society as a whole, as on the holistic needs of our individual patients. And in some cases, this means doing things differently. So there's my challenge to you. So let's move on to the first part, the first section. What is the contribution that general practice makes to high-value care? Starfield essentially looked at 3 different sorts of study that explored the relationship between primary care and between good outcomes. First of all, whether health is better in areas with more primary care physicians. Secondly, whether the people that receive their care from primary care physicians rather than from specialists are healthier. And thirdly, what are the characteristics of primary care that seem to lead to better outcomes? The findings, as I say, were quite dramatic. So she demonstrated over a period of 20 or 25 years using observational data that health systems that had strong primary care, and particularly strong general practice orientations, achieved better health outcomes that included life expectancy, overall premature mortality, hospital standardized mortality, reduced death rates from asthma, cardiovascular disease, and infectious diseases, reduced years lost to suicide, and early detection of cancer. So better health outcomes in a whole range of different ways. She also demonstrated that it resulted in better system performance. So reduced hospital admissions, better value, better distribution of resources, and reduced inequalities. And she also showed that it resulted in better user experience. So better patient satisfaction, higher trust, and fewer patient-reported medication errors. So dramatic results as a consequence of having a primary care orientated system. Starfield described 6 possible ways in which primary care might have an effect in order to produce these beneficial outcomes. And the first one was that primary care, because it's local, because we serve communities, allows us to focus on the deprived populations that could potentially benefit most from our interventions. So there's something about where primary care focuses its attention, which is important. Secondly, she suggested that the way it worked is because we deliver better quality care than specialists too. This was very controversial at the time, as you can imagine, particularly in the United States for a specialist-orientated audience. And there's plenty of evidence that for single conditions, specialists often provide higher quality care. But look at the multimorbidity that we're dealing with, and by and large, generalists provide higher quality care than specialists. Thirdly, primary care allows us to focus on prevention, which is clearly a major advantage. Fourthly, it offers earlier management of health problems. So we manage problems before they start going into hospital, where hospital care is more expensive. Fifthly, we focus on the whole person rather than on single diseases, and that seems to produce major benefits. And then finally, primary care results in a reduced over-medicalization. And we started to talk about this morning. Fewer referrals to specialists, fewer specialist investigations. It's useful, I think, to know all of these features of high-quality primary care, but there is a problem here, because what Barbara Starfield didn't do was tell us which of these features are most important, what is their relative weight, and perhaps most importantly, what will happen if some of them are lost as a consequence of general practice changing. And general practice is changing dramatically. When I first went into general practice in the late 80s, this is where I practiced. I was actually, my clinic was in the bedroom of this converted house. I proudly put up my brass plate in front of the house, and that was the environment that I worked in. This is the environment that I work in now. It's a designed building. It was built as part of the Olympic legacy in 2012 in East London. It's the most phenomenal building, as you can see. It might be in a very deprived community, but it's a phenomenal place to work. So general practice is changing, but it's not just changing in terms of the kind of estates that we use. It's changing in many ways. In most of our countries, we're seeing trends. We're seeing larger scale general practice, smaller practices disappearing, larger practices emerging, and networks of practices. We're seeing an increased role for non-doctors. we're seeing a stronger focus on integrated care, a stronger focus on long-term conditions. And as general practice changes, it's unclear whether the benefits that Barbara Starfield described still actually are relevant to general practice. We don't know whether the new models of care that are emerging at different paces in different countries will still deliver the benefits that Starfield described so dramatically. Let me move on to the second part of my talk, which is why the case for general practice is proving so difficult to make. And I hope you'll excuse me drinking between, because I've got a cold at the moment, so I'm about to start coughing. So why is the case for general practice apparently so difficult to make? Not to us, we get it, we buy it, but why is it so difficult to make to policymakers? If the Starfield evidence is so good, why do we only seem to have convinced ourselves? Why do so many policymakers in so many different countries either not appear to get it or fail to take action, fail to put their money where their mouth is? In most countries, we're seeing very slow progress towards a primary care, general practice-led healthcare system. In some countries, even backward steps. General practice in so many European countries is still the poor cousin to specialist medicine. And the policy attention, and indeed the public's attention, is still rather more on hospitals than it is on general practice. Even in countries with strong systems, traditionally strong systems of primary care, like Denmark, the Netherlands, the UK, we're starting to see a whole range of interventions that potentially damage the important things that we do. In the UK, we've incentivized disease-based care, which has made us go back to a very disease-focused orientation. So there's lots of challenges that we face. So why is the Starfield evidence so difficult to sell to people? Well, let me give you 3 possible reasons. The first one, I'm going to drop my voice and be very humble, because I'm going to be just a little bit challenging. Indeed, I'm going to commit heresy. And just in case anyone wants to do it, this is me burning myself at the stake. That's the Cross of St. George of England on my chest. I'm going to suggest that the Starfield evidence isn't quite as strong as we pretend it is. In some cases, it might even be just a little bit flawed. And the arguments here have been rehearsed before. We know that there's an ecological fallacy. We need to be careful about drawing conclusions about individuals based on data that comes from populations. We know that Starfield attempted to adjust for confounders, but wasn't able to do so in a particularly strong way. We know that there's a series of questionable assumptions in the work that she did. We know there's a strong US framing to the argument that she made. She was writing primarily for a US audience. Maybe even there's a little bit of selective reporting of positive results. I described earlier that strong primary care systems produce better outcomes for cardiovascular disease and asthma. I didn't see what she reported for diabetes. So is there a little bit of selective reporting here? And most importantly, the biggest challenge is that the Starfield data, the data that she used to make her case, in many cases is as much as 30 years old now. So we don't know whether it's still relevant to what we're doing here. And I should also mention that there is some counter evidence, just at the margins, that's emerging. Kringos from the Netherlands has done some really interesting work replicating the Starfield work, but this time only in European countries, and using more up-to-date data from 2009 and 2010. Also using a more sophisticated measure of primary care orientation than Starfield was able to use. The good news is that research largely confirms what Starfield found, certainly confirms that primary care orientation results in a controlling of increasing costs. But Kringos also found that countries with strong systems of primary care, this was published in the BMJ, so it's reasonably credible research for observational research, countries with strong systems of primary care are actually more expensive than systems with specialist care. Now, there are a number of explanations for this, most notably probably a large investment needed in countries in order to get primary care up to the right standard to deliver advantages. And I don't think we should change the Starfield case just on the basis of 1 or 2 studies, but I think we do need to be open to challenge. So that's one reason why the Starfield work might not be as influential as we'd like. The second reason is the allure of specialist medicine. Specialist medicine promises an awful lot. It's very seductive, isn't it? A few years ago, I passed that tender age of 50. This is the age at which you can no longer pretend you're 21, even though I'm still trying to do that. And shortly after passing the age of 50, so I'm sure it was all psychological, I started developing headaches and double vision. Rather than doing what I should have done, which is go to see my GP to be reassured, I made the dreadful mistake of phoning up a neurology colleague in Oxford. And I said to the neurology colleague, I've got a headache and I've got double vision. I think I've got a brain tumor. And I'm not usually hypochondriacal, but there was something about passing the age of 50 that obviously upset me. And he said, Martin, why don't you try a pair of reading glasses? So I tried a pair of reading glasses and my brain tumor got better. So as you can see, specialists are extremely clever people. Specialist medicine is sexy, isn't it, in comparison with generalist care. The public get excited when cardiologists save somebody's life when they've had a heart attack by inserting a stent. But they don't seem to get excited when we as GPs prevent them having a heart attack in the first place. As David Haslam so beautifully said, even the person who didn't have a heart attack doesn't know that they didn't have a heart attack. So there's something about the allure of specialist medicine which is deceptive. And then the final reason why the Stafford work might not have been as influential as we'd like it to be is, again, I'm going to be critical of ourselves, actually, as GPs. I don't think we play the power game very well. Because our focus is on individual patients, I don't think that we exercise power in policy circles, with a few exceptions, as effectively or as strongly as specialists do. Specialists are very good at getting their message across to policymakers, whereas we just assume that what we do speaks for itself. And sadly, it's quite clear that it doesn't. Sorry, that's the Kringos work. So let me move on to the third area that I want to discuss, and that's how general practice, I think, might need to change in order to retain its central importance to health systems, in order to build, if you like, on Barbara Starfield's amazing work. I think there's a paradox in what we do as GPs, because on one side, nothing changes in our job as clinicians. Our job is to understand the human condition behind the closed door of the consulting room in the same way as our predecessors and their predecessors, our fathers and their forefathers have done. So there's something unchanging about the nature of general practice, which is reassuring. But on the other side, society is changing dramatically and rapidly around us in terms of people's expectations, in terms of their needs, in terms of the use of technologies. And I think there's a risk that as we keep our head down, focusing only on the things that don't change very much, the world bypasses us and starts to marginalize our role. So what should we do about that? Well, we certainly need to focus on preserving the traditional strengths of general practice, our whole person orientation, the biopsychosocial and spiritual model that we all adhere to, seeing people in their wider context, learning about their fears, their expectations, and their preferences over time, acting as their advocate, managing risk of over-medicalization and over-specialization. These are core characteristics of general practice that we mustn't allow to change. These are the ones that, as a specialty, we need to rigorously defend. But I'm going to argue that we're more likely to preserve these traditional strengths if we expand our interests rather than just defend our traditional territory. And there's three areas that I'm going to suggest that we could or should be expanding our interests. And here's the first one. We need to play a more significant role in the health systems that we operate in. No one understands the complexity of health systems as well as a GP. We're exposed to the way our local health systems work on a daily basis through our patients' experience and through our own experiences. We know how it works. We know when the system isn't working. We know which are the strong parts and which are the weak parts. We're health system barometers, predicting good weather in our health systems and bad weather in our health systems. And these insights, I think, give us enormous responsibility. All of us, every one of us, need to be system monitors and reporters, recognizing when something's going wrong and reporting that back to people. A good number of us might want to be system improvers in our local health systems alongside our role as clinicians. And a few of us might want to become system leaders, perhaps as managers or policymakers or as academics. It could be difficult, of course, to ask GPs to take on these non-traditional roles when we have so many clinical priorities in our lives. And in particular, I think, when GPs aren't trained to take on these roles. We don't know enough about system improvement. So often when I say this, particularly to my junior colleagues, they say, but that wasn't what I was trained to do. That isn't what I want to do. But my argument back to them is that if we let our systems be run by people who don't understand general practice, who don't understand what patients want, then all we can do is sit back and complain, and that doesn't really seem to be acceptable to me. In many countries, we're seeing a growing number of GPs who want to take on these leadership roles, who are holding their own budgets, who are commissioning services, specialized and primary care services, who are prioritizing and moving funding from one sector to the next, where it produces the most cost-effective results. Many of these people are young GPs who have a growing interest in early career fellowships and are developing insights and experience into how systems run, and with a very strong potential of them becoming amazing future leaders with extraordinary influence on their health systems. So what do we need to do to preserve this? I think it requires us to develop the knowledge and skills of what you might call improvement science, evidence-informed improvement. It requires us to understand systems and how they work. It requires us to understand the principles of system improvement, the skills of leadership and of influencing. All of these are essential skills for a modern clinician. And those who say we can't fit them into our packed curriculum, I'd probably remind you that these are skills that are probably more useful than the insertion point of tibialis anterior or the classification of glycogen storage diseases, which I learned about when I was a medical student. So there's something about teaching medical students what they really need to know. Let me move on to the third part. The second suggestion, taking positive action about the social determinants of health. You'll remember Mohammed's story, in which I described how much of his ill health problems are a consequence of social problems. The evidence is that 70% of our health is the result of wider determinants than simple biomedical disease. And we know from data in the UK that people living in the poorest neighbourhoods, like Mohammed, live 7 years fewer than people who live in richer neighbourhoods and have 17 years fewer free of disability. As Michael Marmot, a most remarkable epidemiologist in the UK, once described, why do we treat patients and then send them back to the conditions that make them sick? As GPs, we've long recognised the importance of social determinants. The biopsychosocial model is core to our understanding of our role. But I don't think we've been very good at doing anything about it. What do we mean by emphasising that social factors are important? What are the practical implications of saying that? Iona Heath eloquently describes how GP's job is to witness their patients' lives, and by doing so, helping patients to gain insight into what's important. This is clearly a good thing, but is it enough? A small number of GP-based practices across Europe have moved beyond defining themselves in simple health terms and are starting to look at wider determinants. The Community Health Centre Botermarkt in Belgium would be one example. The Castelanga Health Centre in Finland would be an example, and the Bromley by Bow Centre where I work in East London. And I want to tell you a little bit more about the Bromley by Bow Centre because it's a really interesting model that maybe we'll want to replicate in the future in primary care. The Bromley by Bow Centre was established in 1985 by a church minister in one of the most deprived communities in the UK. The population there is young, it's rapidly growing, it's highly ethnically diverse. 44 languages are spoken on a daily basis in this locality. They have a higher rate of TB, of drug abuse, of diabetes, of cardiovascular disease, and of cancer and of suicide than any other part of the UK. This centre is owned and run by the community, and its focus is on developing confidence and independence and resilience amongst the local community. It's all about empowering people. And it's the most positive place you'd ever want to go to. If ever you get the opportunity, please do go along and pop in, because they'd love to see you. And it is a most remarkable place. What you hear from the staff and the patients who live and work and use services is constant conversations about the assets that they have at their disposal. You never hear them talking about the downsides, the deficits that they have to deal with. The centre is built around a small park, as you can see from the top right picture and from the picture at the bottom. And this was a park that was previously completely run down, but they've converted into a really nice open green space. What they do is provide services that include training and skills, employment advice, family support, a nursery, a community cafe, workshops, an art studio, and an incubator for social enterprises, which over the last 10 years has generated over 10 million euros of income and created 325 local jobs. Oh, and incidentally, it also has a health centre, but a health centre which is really quite unusual. A health centre in which patients are genuinely partners, and in which the emphasis is not on medical prescribing, but on social prescribing. So the whole model is about medicine backing off. It's not about doctors as providers of health services or as healers, but doctors as navigators, helping to create an enabling environment in which patients can look after and heal themselves. I've presented a glowing picture, of course, and of course it's incredibly hard. 30 years of hard work they've put into developing this centre, as I'm sure they have in Belgium and in Finland. It's been really tough. Funding has been a struggle. The model hasn't always been popular. People have asked, why is this model not spread? And that's a really important question. And I'm chairing an advisory group which is starting to evaluate the model, understanding what it is. Some people say, well, maybe it doesn't work at all, but my argument is actually what we do in conventional medicine doesn't work that effectively either, and it's exceptionally expensive. So let's try to use models that have a good theory underpinning them, and let's commit ourselves to evaluation. The final area in which I think general practice needs to change, and this builds very much on the conversations we were having this morning, is in our ability to manage uncertainty. GPs are specialists in managing uncertainty, and Einstein produced a model which described the importance of that role really effectively, the growing importance of that role. So Einstein said, pretend that that black space there is everything that we don't know, an infinite amount of things that we don't know. And let's look at what we do know, a tiny amount of things. And that yellow line around is our zone of uncertainty. It's a zone between what we do know and what we'll never know. What happens as we learn more, as we know more, which is happening all the time in modern society? Well, that zone of uncertainty gets bigger and bigger and bigger. So the job of the uncertainty specialist, that's us, GPs, is going to get more and more important as our knowledge grows. And for every, I'm going to call them certainty specialists, cardiologists, urologists, whatever you want, we're going to need more uncertainty specialists in order to cope with the side effects of being certain. So our job is going to get bigger and bigger as time goes on. But this presents major challenge to us because even now we don't know enough about the role of the uncertainty specialists, how to manage uncertainty. It's been estimated that around about 40% of our time in general practice is spent managing problems which are well defined and for which is a reasonable level of certainty about what we should do. That means 60% of the time we're dealing with problems for which there's no right answer, or paradoxically, more than one right answer. Recently, I saw a 48-year-old woman who'd been told by a practice nurse that she had pre-diabetes. So I'm going to be building on Paul's story about pre-diabetes from this morning. She came to see me to discuss what the diagnosis actually meant, and she was actually really quite angry. She sat down in a chair opposite me and she said, Dr. Marshall, just tell me the answer to two questions. Have I got a disease or not? And why have you prescribed metformin for me? Those are really good questions. And my answers to the first question, have I got a disease or not, was, well, maybe you have and maybe you haven't. And my answer to the second question, should I take metformin for it, was, well, maybe, but maybe not. So these are classic answers to problems of uncertainty. The problem, I think, is that uncertainty is a problem that won't go away, and screening for diabetes is a really good and bad example of a paradox. Most importantly, what we're dealing with here is an arbitrary judgment. Paul described briefly how the cutoff point for diagnosing prediabetes was recently reduced by the American Diabetes Association from 6 to 5.7%. Overnight, that increased the prevalence of prediabetes. This is a condition that might not exist, I say quickly. It increased the prevalence of prediabetes by 3-fold. Does that sound right? Are we creating illness in what we're doing? Paul quoted Huxley, who said, medical science has made such tremendous progress there's hardly a healthy human being left. I'd also like to quote Burgess, who said, a healthy person is one who's been inadequately investigated by their physician. So where do you stand? Some doctors are disease deniers and some are disease mongers, and a good GP, I think, can only make sense by being both at the same time. And that's the paradox of being in the front line. The problem, I think, is that we tend to get valued and rewarded for the simple stuff that we do as GPs, and the more complex stuff is not valued or rewarded. So what do we need to do? I think as GPs, we need to talk about uncertainty more with a sense of pride. We need to manage it as a core role that we take on. We also need to have better research to guide us about what's important. We need to understand that managing uncertainty might be a new thing in medicine where we tend to specialize in certainty, but actually Charles Handy in the field of business has been talking about uncertainty for a long time. He said that most of the decisions that we make are not between right and wrong, but between right and right, and I think he's right in that respect. And finally, we need to be teaching our juniors and indeed ourselves about how to manage uncertainty. And there's a lot of work going on to the development of practical wisdom at the moment, what Aristotle called phronesis, which I think helps us to deal with uncertainty. So let me finish with this quote. 50 years ago, Rosemary Stevens, who was an American sociologist, said if the general practitioner didn't exist, he or someone like him would have to be invented. 50 years on, the only thing about that quote that needs to be changed is the gender imbalance. I'm confident that general practice has a very important future, and if we weren't here, we would have to be invented. Optimists tell us that we shouldn't let a crisis go to waste, and there's never been an more important time for general practice to demonstrate its importance, not only to individual patients, but to health systems and society as a whole. General practice is the jewel in the crown of our health services, but I think we need to recognize that it isn't a hard, resilient jewel. It's quite a delicate jewel that needs to be looked after and nurtured. In this presentation, I've tried to make a case that we need to continue what we do, continue to value highly the core aspects of general practice role. We need to continue to be looking after patients like Mohammed and recognize the uncertainty of that. But actually, we also need to do some other things differently. We need to be much more focused on our role as health system leaders, more focused on the wider determinants of ill health, and more focused on our role as uncertainty specialists. Thank you very much for listening.